As you can tell, we record these meetings. We do them every Friday morning at 9 o'clock, and you can see some of the repeats from that over on the neurocentricapproach.com/blog, the blog tab there on Neurocentric Approach. And you can see the recorded meetings that we've had in the past. All right, we'll get everything set up over here. Got a gorgeous day in Portland. Well, gorgeous for this time of year, which means we've got some clouds, but a mix of sun. Everywhere else in the world I've ever lived, they call that partly cloudy skies. Here they call it partly sunny. But yeah, it's looking like spring out there. The pollens are down a little bit this week because we got some rain, so the air is a wee bit cleaner. And I'm kind of digging that because then I won't be quite as flimmy for you guys. Welcome to March Madness weekend too. It's been a fun tournament so far. I am, as many of you might know, I grew up a North Carolina State fan, went to State for a few years in engineering school there. And I was there when the 1983 Cardiac Pack won the whole shooting match in the NCAA men's tournament. Have some pretty fond memories of that time. And the way this team is shaping up this year is kind of setting up like that. Although it's going to be fun to see them play Oakland today and see if they can put a muzzle on Golke and keep him from those 3-pointers. And if they can, I'm liking DJ Burns and the Pack's ability to possibly shut them down. And fascinatingly, if they do that, coming ahead on them in the tournament, they might run into Marquette. And the year that they won their championship, they actually, if memory serves, they beat Marquette in, I believe, the Elite Eight, or maybe even the Final Four. I don't know. I have to Google that. All right. So as folks are coming in here, welcome in. Welcome in, Dr. Heller. Appreciate you showing up, sir. And good morning, Heather. Good morning, Heather. Good to see you. Heather, you going to be with us in Portland or not? Give me your audio there.
No, I couldn't leave my husband with the kids for another weekend. That's the only reason.
Understood. Okay, well, we'll leave lights on for you there and hopefully get you an upper quarter course in the neighborhood at some point. I'm looking right now at Vancouver and trying to put something together there, hopefully in the summer. So if we were to do it there, you can take the kids, take the husband, and go up for a weekend and make a vacation out of it.
Yeah, that could be fun. I'm actually going to Vancouver like 2 weekends after the seminar for my 55th birthday, and that's kind of interfering with my ability to leave on the 21st.
Copy that. Copy that. Well, I completely appreciate balancing those issues. All right. Let's see. Yeah, in fact, speaking of that balance, my wife is up in Vancouver right now. Actually, she's in Whistler right now. She drove up yesterday to rendezvous with my son. He's got the weekend off from school, and they drove up to Whistler last night, and we're going to try to get on the snow this morning and hopefully get some decent turns in. And that opens things up for me here with the NCAA tournament. So it means that I can go all in. So I was sitting last night with three screens around me. Actually, four screens because I was watching a new Three Body Problem on Netflix, and I'm finishing the third book in that series right now. It's and the I will say that the book series for me has been a little bit hard to read because it was a Hugo Award winning. All three of them, I think, were Hugo Award winners, but it's a Chinese science fiction series, and the translation, it was just a little difficult, and the way that it was written, it goes forwards and backwards in time quite a bit. It's a little bit difficult to keep track of. But the folks that made Game of Thrones are the ones that are doing this series, and they've taken a little bit of poetic license with it in the same way that they did with the Game of Thrones series, Song of Fire and Ice. And I think they have once again knocked it out of the park. I watched the first two episodes last night. You guys ought to check that out. Let's see, what else? Other things that don't have anything to do with NeuroCentric approach or that kind of stuff. I just had a artist brought across to my attention, guy by the name of Marcus King this morning by one of my former classmates from when I was at North Carolina State. And check him out, Marcus King. Incredible voice. Sound, yeah, I wrote back to him. I said, it sounds like somewhere up in the great beyond, they mashed Leon Russell, Greg Allman, and Stevie Ray Vaughan all together, and then sent them back. And this guy's got incredible pipes, plays an incredible guitar, and is an incredible songwriter, and has a great band behind him. So Marcus King, check him out. All right. Anybody got any social stuff or anything else? Any problems you're running into with NeuroCentric approach, integrating it? Anything on your mind this morning? Go ahead and pop off. Chat me up.
Is it just the three of us?
It is for the moment.
Yeah.
These are recorded, so everybody jumps in way later on the recording. So a lot of folks do that.
I had one patient who came in with so many postural, like she was scissoring and really low body tone, muscle tone, and she didn't really have positive orthopedic tests. So I was feeling like she was having a whole slew of entrapments, like the cluneal nerves, and but her pain levels were so high, and I think her commitment level was low, so I only got to see her about 3 times. And I tried to do some of those, where you grab the fascia at the lateral obliques and try to loosen that up, and did a little bit over by the TFL, and I mean, she felt a little bit better, but I felt like there was so many things to work on all at once. I wasn't sure.
What was her presenting complaint?
I'm going back about 5 weeks here, but she had lateral hip pain that but it wasn't like trochanteric bursitis-y kind of pain. Um, you know, bilateral lumbosacral SI pain, but mostly the hip pain. And then she also had some neck and shoulder, um, which sounds very typical of what
Mhm.
I see every day
Yeah,
in
yeah.
chiropractic. But oh, and she had like her left foot would swell, her ankle would swell like she was having maybe some tarsal tunnel if
Mm.
she wore heels. So like when she got married and she wore heels for part of the day, then she gets a bunch of swelling
Just on one side
just
and
on the left side.
the
Yeah.
entire ankle, or in the medial calcaneal region where the
So medial distal tib, I mean, and but like, yeah, the whole foot would kind of swell, but it seemed like there was a bunch of connective tissue bogging things down on that medial tibialis.
how how old is the patient?
About 35, I think.
Okay, so relatively young there. Okay. So the yeah, the index of suspicion for things like neurogenic or vascular claudication drop then for possibilities of that. Um, does she have any kind of so let me pause for a second and just talk organization and case management on this kind of stuff for the benefit of any listeners and everything. Everybody that's on here over on Zoom, you guys have been at the game for a long period of time, so you know the the process of ruling ins and out, red flags and systemic stuff and all of that. And that's important, but since we'll have younger folk coming on here and watching this and everything as well, if you've got observed swelling and unilateral swelling like that, we want to consider possible systemic contributors to such things. When it's on one side of this, we're an older patient, I'd be a lot more concerned about something going on in the common iliac arteries and maybe some sort of vascular claudication process. And I want to follow up with to make sure that their blood lipids and cardiovascular status is being managed by someone and somebody's tracking that. 35-year-old, a lot less likely. First thing that would pop to mind for me there would be to explain a unilateral would be some sort of venous insufficiency problem. She have nasty varicose veins or anything of that sort, Heather?
No, I was just able to pull up her initial visit. She's 32 and she hurt herself picking something up and something popped or locked in her back. Um, and she got some physical therapy in India. And but then it got really bad again and it was tender to touch, lateral leg needle pain with palpation, um,
Lateral leg needle pain.
needle-like pain with when I touch it with palpation.
Okay. And that was consistent with which nerve?
Um,
Was it consistent with lateral femoral cutaneous?
I'm kind of jumping in a sink or swim situation here.
Yeah.
Um, let
Or
me
was it
see.
more consistent with something more proximal and more lateral, like the lateral branch of the iliohypogastric nerve?
I was feeling it was more proximal. Yeah, like that one.
Okay. So the lateral branch of the iliohypogastric nerve. Okay.
Yeah.
Got it. So then if those sorts of things to explain the swelling downstream, once those have been accounted for, um, and I don't think we got an answer on the vascular insufficiency, any kind of venous insufficiency issues.
No, nothing was noted there.
Okay.
The circulation,
So if
was,
it
well,
if it truly let's work from distal up in that one, since that is, you know, potentially a more serious health issue for the patient that needs to be explained. If she's got something that is causing a little bit of a swelling in that lower extremity, that could potentially cause a mild, functionally present anterior compartment syndrome that can then start to explain the local observed sort of issues with the posterior tibial nerve, the sural nerve, or the superficial fibular nerve. So those are things to consider if this is an intermittent kind of process there.
mhm.
Working back upstream in case conceptualization, when I've got somebody that's showing, you know, a laundry list of things they've been sitting around unseen for a long period of time, and have several presentations that they're hoping that you're going to be able to, you know, work with them on in the space of an hour or whatever you use for your new patient intake. I generally organize the patient in terms of I'll ask them to rank order their presentations for what is most painful and what's interfering with their function most. And in this particular patient, it sounds like the low back pain with radiation into the right lateral hip after that single event are worth noting. And in the areas that you've described so far, it's likely that we've got some involvement of a nerve based on where you talked about with the burning symptoms on the lateral hip. Sounds like probably the lateral branch of the iliohypogastric nerve, but rather than getting, you know, focused right on that, you've done the overall in your visual of looking and seeing an open scissors presentation. I don't know if anything showed up in the history to suggest any kind of a stress component that might be going on in this particular patient. That could,
I'm project manager, you know, so there's that stress, newly married,
yeah.
um, you know,
So
went to India to get
I asked
married.
that I asked that to try to explain some of the potential open scissors posture um, as a result of an apical breathing pattern, kind of throwing that off. And if we've got that for a period of time, then the adaptations will sometimes result in issues in the shoulders and issues in the hips.
Mhm.
So um, everything that we're doing in that first visit, the way that I organize it is, one, find the tissue that's complaining the loudest and see if you can identify that tissue. And then we reverse engineer from there. It,
Mhm.
can you provide a symptom modification for the tissues that are there? Are you able to turn it down? Can you turn down the heat on that? If you are, can you teach the patient to do something like that, to turn it down regularly between first visit and second visit, so that we can
Mhm.
get some, you know, positive slope on their benefit curve? And then third, always the most important thing is the functional contributors to this. This will lean into some things that Mark was talking with me during the week about gnawing, and the need to balance out those forces around the pelvis. That open scissors position is an adaptation often to threat from something, and possibly you remember from the fix your own back material, presentation of threat vis-a-vis the body's perception of compression and additional flexion in the lumbar spine in the presence of a disc issue. Will cause the body to tighten those lumbar erectors and try to hold that position in place. And then you wind up with the lumbar erector muscles and some of the abdominal wall muscles becoming secondary sources of nociception by virtue of the acidosis in that tissue from that chronic tightness in response to the perceived threat. The mechanical interruption of the slidey-glidey interface of the iliohypogastric nerve, the cluneal nerves, the ilioinguinal nerve, all of that can cause those hot spots. And we refer to that as Main syndrome and polite conversation.
Mm-hmm.
From a functional perspective, beyond doing the things at the thoracolumbar junction, manipulating there, mobilizing there, and doing the things in the tissues at the interface points in the posterior and lateral abdominal wall, we also want to address the functional issues. So in the first visit, often I might point to the functional issues, but not lean into them really hard. I kind of introduce it, and then I roll into the functional stuff quite commonly on the second visit a little bit more, because again, if I can turn the pain down or off, and we use the clinical audit process to kind of show that, then I've got buy-in from the patient. If I can get them to then do something to help themselves with that pain during the week, then we've got that steady build. And then I can come underneath and have that conversation about functional and systemic issues in the second one. That's a triage issue, right? That's a little more the art of being in practice for a good number of years, and realizing, one, you ain't going to get everything done in the first visit. And two, if you come in there on that, for an analogy, that patient that's in the emergency room that's bleeding out, and on the blood panels, they notice that the patient is hyperglycemic, it's not the time to talk to them about, as they're bleeding out, about about managing their blood glucose a little better.
Yeah.
So in this case, I would definitely lean into that functional component using, for me, my preference, my bias is the DNS material, as is yours, and I would go there. Now, if I get to all of that and it's like, this is too much, and I'm still kind of confused on some of these, here's the trade secret from my vantage point. If you've got DNS skills in your basket, you can almost always lean on those and have benefit on the patient. It's going to take longer though.
Yeah.
And in some of these cases, that the tissue issue is a little bit less clear, and or my inputs on those tissue issues are less forthcoming, then I'll lean into the functional stuff and see if I can keep the patient engaged on that until we can get some positive improvements. But we've talked before on here, just a sec, Mark. We talked before on some of these about that adaptation per DNS in the absence of that first domino being the adequate intra-abdominal pressure and diaphragmatic stereotype of breathing. Then we develop an adaptation in the lower quarter and the upper quarter. And the lower quarter adaptation looks like this when the hip is asked to move in the absence of a precedent of a stable lumbar spine, then the psoas will first have to pull slop out of the lumbar spine. And as it pulls the slop out of the lumbar spine,
What?
as it pulls the slop out of the lumbar spine, it will change the conformation of the femoral acetabular joint, and then you can start having a pinch in the front of the femoral acetabular joint. And you'll have the functionally tight psoas that shows up as spine, and the patient reports that they stretch their psoas all the time and they can never get their hip flexors to release, blah, blah, blah. And in the upper quarter, that patient, that's Hodge's work. The first group of muscles when you or I move our arm is that contracts. The first group of muscles are the deep stabilizers of the lumbar spine, and the second are the stabilizers of the shoulder, namely the serratus anterior. If that serratus can't communicate clearly with the external oblique in that case because of a problem with that lumbar spine stabilization, then a reroute goes to the upper trapezius, and the shoulder shrug occurs, and the scapular hiking occurs with any kind of overhead movement. And then we wind up with a change in conformation and the kinematics of the glenohumeral joint. We start to have joint issues there, which that'll be the topic of our conversation case-wise today when I get around to that. So I don't know if that helps at all with conceptualization of that. Heather?
Oh, it's definitely helpful.
Let's lean into Mark. He's chomping on the bit about something over here. So let me get him on here. What you got, Mark?
My question on this case is back to neurocentric brain, spinal cord, moving down into the other nerves. This thing started with some kind of low back injury. Is it possible that a bunch of this stuff is still, a lumbar disc? And have we checked strength of L4 and L5? Have we done straight leg raise kind of things? Have we done seated compression? That would be bigger picture than peripheral sensory nerves.
My initial exam was really focused on that, and my initial diagnosis was radiculopathy, and there was increased sensation of L4, L5, S1 on the right. They had multiple positives, and I was treating it. I did some auto flexion distraction on the table, and I tried to open up the joints with the drop table, and I did home exercises for talking about lumbar neutral, and talked about ergonomics, squaring up the pelvis, and I just kept feeling like there was that going on, but in addition to that, there was some peripheral stuff going on.
Yeah.
Like
so
peripheral
what Mark's doing here though is really salient in that we want to go back to that big neuro to small neuro, and what you've described so far in the case presentation was mostly focused on the patient's perception of what's happening at the small neuro stuff, but seeing a precedent that a threat presentation with a lifting issue involving a pop and a patient of that age, that is a mechanism for some sort of a spinal, likely disc issue. And if they've got the flexion intolerant presentation there, and you've already identified the myotomal deficits on that side, then we've got a driver for the threat presentation that's going on there. And that will be the first order of business, turn that down. So usually once I get through that examination and I've determined that, and I set that pen up to knock down first, then I'm going to do symptom modification procedures. And that's my first one that I go to is not because of preference, it's because of ease of compliance with the patients. It's MDT. So I'm going to put them through an MDT screen and look for a directional preference and see if that turns some of the pain down. If it
What is
does,
What is
did
it?
it? That's Mackenzie's work.
Oh, okay.
So we'd start off with the one that's most commonly useful in that was extension, repetitive and range loading and extension, so prone press ups, and start with an index test to see if there's something that the patient does that causes them pain. We do the symptom modification with prone press ups, have them repeat the index test and see if that's better. If it is, beautiful, that goes home with them. If that's not so apparent as a symptom modification procedure, then I'll lean into NDS, that's Michael Shacklock's neural dynamics kind of stuff. And primarily on this, less involved with the dynamics part, just about creating space is a static opener. So I'll lay them on their side and get some opening on that involved neural foramen. And 5 reps of 30-second holds in that sideline position with the legs down that we went over in Seattle when you were at the course. That will be the go-to there then, if that's the one that works best for them. So. All right, anything else? Welcome in, folks coming in over here on Facebook. Okay, case today. I'm going to recap briefly the 82-year-old that we talked about last week. She came back in for her second visit this week and was pleased to say that she was 50% better. That's the most long-lived improvement that she's had from anything in 9 months, including injections at the target neuro. Mark, you'd be pleased on this. Her background, as we got to talking with her and her husband, they met at Esalen back in the day. So we had some good talks about Esalen and all of the interesting things that had come through there. She had been there studying Feldenkrais, which was one of the first things that I ever got involved in that got me interested in therapeutic applications of any kind of exercise and manual therapy. So that was good. But we went back and took out the Sharpie marker, marked the spots that she was having issues with. In lateral, her lateral hip pain along the lines of what Heather and I were just talking about. It was a lateral branch of the iliohypogastric nerve that was hot for her. So we did the lateral mob that Heather you saw in Seattle of laying on the side. You do a deep tissue pull through the abdominal wall. You find the ropey spot and then have the patient twist with the arm in one direction, leg in the opposite direction, alternating back and forth while you provide both DTM tissue opening kinds of procedures there, and then a TNM, transverse nerve mobilization, by getting in deep and getting on each side of the nerve and trying to bend the nerve while they're doing this. And instructed her husband on how to do that because it's difficult for them to drive in the city. They're coming out of the country and driving an hour and a half to get to Portland. And it's kind of difficult for them to make that transition. And the other primary spot for her was the medial branch of the superior cluneal nerve on that side. And she had hot spots at both the osteofibrous tunnel where the nerve arises through the thoracolumbar fascia, And then where it crosses the ilium and dives into the gluteal tendon, that point was hot as well. So we worked both of those, both with cups, using dynamic cupping, in sideline position with her working the hip into flexion and extension. And and then I use TNM in the clinic, but I showed them how to use cups at home for that. And then we went out and took a nice long walk. And her walking tolerance, you guys might recall, was about 20 yards reported when she came in before, but after a few days of rest before she'd see me, we were able to triple that out of the gate. And then after some therapy, we were able to get that up over 100 yards, as I recall. We were able to once again go out and walk to the point of her limiting factor, and the walk was knee pain on the right knee. And at least some of that is due to saphenous nerve involvement. So I showed her manual therapy for the saphenous nerve as well, and gave her some squat work as well to work on the functional causes of that, start building a bridge between the stuff that's going on in her low back and the stuff that's going on in her knee. And we'll see how that continues to trend. But the main one I want to talk about today, that we talked about a few weeks ago, I think, is my power lifter, a woman, female masters athlete, 42-year-old world record holder in her sport for cumulative totals. The 3 lifts, of course, in powerlifting, bench press, back squat, and deadlift. And she presented with right shoulder pain at the very bottom of the bench press. So that point where the eccentric movement of the weight coming down stops, and the concentric portion of the movement starts with the push out. And she had, you guys might recall that the very first thing that I did was we modeled her index movement on a seated chest press, and she was able to reproduce the pain with that. So there I had an index to work off of. And I stood behind her and just provided manual cervical traction while she did the same movement, and her pain completely went away. So that suggests to me that the origin of whatever it is that's going on in that shoulder is probably emanating from the neck. And in a patient of that age and that status, we're on the bubble about a disc, and more likely to be a spondylosis kind of thing. So again, leaning into the 2 symptom modification things that I would typically go to. I started with McKenzie for the neck and did retractions. That didn't change her index movement at all. I then tried static openers for Shacklock. That didn't change her index at all. So I tried to look at a home version of what she could do that mimicked what I did in the clinic that helped. So I did a distraction, cervical traction kind of thing. So I set her up with a way of doing cervical traction at home and in the gym. And she had benefit the next week, pretty significant drop in her symptoms. But she continued to have some pain there, and we were playing a whack-a-mole kind of thing. She would go in and she would train, have 2 bench press sessions in the week between our visits, and flare the peripheral neurology up in the shoulder. And then I'd have to try to spend most of our clinical treatment putting the pain relieving strategies of heat, stem, manual therapy, and such around the shoulder just to calm things down. And that gets frustrating trying to put band-aids onto something while she's trying to continue an anabolic process of growth. In her case, one of the things that we were able to identify functionally was that her arms on the bench were out here instead of down here, and we wanted a spiraling movement which would better integrate the serratus anterior to the core on her bench. When we were able to do that, that helped with her index, and we were able to shift our index then over to something that looked more like her actual bench press and put her down on her back with some weight over her chest. And what we then found was we could take off some of that initial functional position challenge by providing a liftoff, or handoff. And that handoff actually happens in competition. A spotter will stand over them and put their hands on the bar and help them get the bar off of the rack and into the start position. And we were able to find that when she had handoffs, she was able to completely bench without any pain. And she had, week before last, 2 pain-free bench sessions. Her target for the world record in this one will be 194. The world record, I think, is 193.5 in her age and weight class. In her first bench session of the week, she went 183 for 2 reps, and then 187 for a single with no pain. And I was like, yes, we got it. And then she came back this week. At her second bench session did not go as well. And I only caught her in the parking lot, and between her finishing that session, and she was a little down in the mouth because things had flared up. So that one is a struggle, and it's part of what I want to talk about, that combo platter of meat and nerve. So let's lean into that. Some of you that are tracking this particular case are probably wondering, hey, Cairo, have you done any manipulation on this patient? And yes, I have. I've manipulated her cervical spine into opening procedures for the involved neurology in the neck. I've done manual traction in the cervical spine. Using a regional interdependence model, I've gone down to the upper thoracic and explored that, and indeed she is stiff there. We will commonly see that over time as power lifters get stronger, owing to the demands of the sport and the often, I won't say overlooked, but underappreciated need to manage overhead mobility in the shoulders. They'll become stiff in the upper back. And when they are stiff in the upper back, the way that starts to trend is initially they will start showing up with this kind of issue in the shoulders on bench, but the actual problem is typically happening in that athlete under the bar on a squat. And they don't have any pain in the shoulder on the squat. It's that their shoulder mobility is being reduced to the point that getting their hands back in a position to position the bar effectively, especially in a low bar squatting position, they will have to crane their neck forward, narrowing the neural foramina in the cervical spine, while they've got weight right on that particular area. So that, and then the neck, if they, especially in their coaching, if they're eyesight is to, they've been coached into a head up position. Then as they descend, they get a pinch right there at the neural foramina. And that we will oftentimes see will cause the spondylophyte to piss off a nerve root right in that area. And then they don't notice it until they come over to their bench session a day or two later, and then start trying to push. So we've been working on those with each session. But as we start to have that downstream, we'll call it subclinical radiculitis, because radial nerve shows fine on her, median nerve shows fine on her, the ulnar nerve shows fine on her on upper limb neural tension testing. But the suprascapular nerve was hot as a pistol. And we work all the way downstream on that. It was tender in the supraclavicular notch. It was tender at the suprascapular notch. It was tender in the infraspinatus. It was tender in the supraspinatus. And as you guys recall from taking the online shoulder course, that suprascapular nerve is also the innervation of the posterior third of the glenohumeral joint as well. And her pain is all on the superior and posterior aspect of the shoulder. So it's all leaning towards suprascapular nerve. And my mobilizations, and I go down that way and I use DTM with cups right over that suprascapular notch. We get a little bit of temporary improvement. When I go in and I do TNM, that actually seems to relatively consistently piss it off, which to my mind shoves us back upstream, that I'm working on a mechanically sensitive nerve and I'm applying a manual input that's directly on the nerve. And if it's not healthy enough to be able to manage that mechanical load that I'm putting through it, then the issue is not likely an entrapment issue locally. It's an irritation issue further upstream that still needs to be addressed. So that leads us back into locally a tissue modification procedure at the cervical spine and a functional modification using a regional interdependence model. Now, if this persists, the way these tend to play out, with that irritable nerve in that area, the body will start to adapt to that threat by changing her mechanics. And then her mechanics in the shoulder will start to look like a hike to try to get rid of any kind of traction on that neurology. Our attempts at doing neural mobilizations in that area didn't really buy off much. We'll talk more about neuromobilizations for that suprascapular nerve and get a little creative on that at the upper quarter course in Portland, April 20th, 21st.
Can I throw something in on this one?
Sure, go with it.
So, one of the things that I notice, and this is not about this case, but about we're dealing with C5-6 problems. And typically there'll be a hypertonicity of the scalenes, and the manipulation that I do, and I hesitate to use the word manipulation because it's definitely more a mobilization approach, is an anterior to posterior mobilization of the lower cervical spine. And this interesting exercise that I developed a long time ago that I called chin to collarbone, which is designed to try to quiet the scalenes by activating the deep neck flexors. And I'm going to demo that here.
That's almost a little strain counter strain kind of procedure, and your neck.
Well, strain counter strain is strictly a
Your,
positional thing,
your neck to
technically. And this is,
collarbone,
I always use more, pardon me,
and your neck to
I don't know
collarbone.
how good my,
Yeah, we got a little bit of lag, but the neck to collarbone thing is one of the entry level tests on the SFMA too, as a mobilization. So I see the system mixes there. All right, go with it.
so anyway, the exercise looks like this. You're palpating in the lower neck and it's tight and painful. And the person starts with kind of like a Mackenzie retraction, tuck the chin. I imagine a balloon lifting you. That's number one. Number two, turn toward the side of involvement 20 or 30 degrees. And number three, take the opposite hand and give resistance, not isometric, but through the range. And the person brings the chin to the collarbone. And when the person needs to be precise. People get sloppy about it and they do a chin poke instead of a tuck and tip. But when it works, scalene's quiet down and it's less tender. So that's that's the exercise. And the mobilization is kind of a modified muscle energy. I'm trying to push C5-6 anterior to posterior, and at the same time dealing with the lateral component. So I don't know if that's useful to anybody, but I thought I'd throw it out there, and it sounds like it might relate to this difficult weightlifter case. So
Thanks, Mark. It's always interesting too to hear all of us that have been playing this over time to see how the quilt starts to look as we seam these different things together. As I hear you talk about those and that MET and some of the things that you're describing there, I'm reminded of some of Carl Levitt's inputs into that area, addressing quote unquote first rib, which are mostly the scalene, anterior and middle scalene issues. I like your thinking there as well of including the scalenes because of the proximal relationship of the anterior and post and middle scalene to the brachial plexus and the possible association with that and the shoulder issues. Those are worthy of inspection. Our inspection on this downstream, all of those brachial plexus peripheral components were tracking well. There was no mechanical sensitivity noted on the stretch tests. The other proximal relationship that's worthwhile here that we'll commonly see with these C5-6 and C6-7 issues is the dorsal scapular nerve. Remember that the dorsal scapular nerve pierces the middle scalene, and that is one of our interface points. So if in the constellation of symptoms with a patient that's got neck/shoulder pain, they also report that there is an issue intermittently often in the mid-scapular region, then that's an area to be interested in. And they'll often have, if it's severe enough, a bit of medial border of scapular winging owing to the motor innervation of the dorsal scapular nerve to the rhomboids. Again, in this particular patient, we didn't see that so much. She had good scapulothoracic glide, good ability to recruit, and I wasn't able to reproduce any symptoms into or cause any symptoms into the mid-scapular region with palpation over the scalenes. To thoroughly investigate that, again, from a NeuroCentric approach, backing up and looking at other potential contributors, should that show up, would be respiratory stereotype, an apical breathing pattern using the scalenes and tidal respiration could potentially provide the mechanism as well for that interface dysfunction at the middle scalene and the involvement of the dorsal scapular nerve. Again, in this particular patient, not showing up. So the combo platter that typically shows up on this, and I have certainly seen this in lifters, is the threat is presented at the nerve, and then the body adapts to the threat by changing the biomechanics that alters the position of the joint. Specifically in this kind of case, the way that the movement changes is a shoulder shrug occurs on the affected side, scapular hiking, if you will, with any kind of movement from 90 degrees and above. That alters the glenohumeral kinematics by shifting the humerus anterior in the joint. And that causes a bit of potential altered biomechanical forces on the bursal and the humeral side of the rotator cuff tendon. So we will often wind up then with call them trigger points in the upper trapezius, which to my mind, I'm looking typically there at either supraclavicular nerve interfaces over the upper trapezius or dorsal primary rami interfaces in the upper trapezius as being the source of that palpable knot that we're playing with in that area. And if so, I would be manipulating T1, T2 quite handily in that particular area to try to open that up as well, and working on the McKenzie retractions with extension and rotation to try to get the person over the sore spot. That's a little nugget that I've learned as well, and where I part ways with the McKenzie folk, where they would usually refer to pain with retractions on the initial retractions as a derangement syndrome. And then if you do the retractions and their symptoms get worse, you don't continue on that. And take care, Heather. The retractions, they would then not typically lean into retractions plus extension and rotation. And I will go there, but really coach the patient into lengthening of the neck as they do their tilt. So the retractions, and the retractions plus extension. And when they run into the pain, try to lengthen their neck over that painful spot to involve the unirritated joints below the irritated joint in some of that extension. And often we're able to get the patient over that sore spot. Sometimes you have to go in and do some sort of manual input to the upper thoracic spine to mobilize that area first, so that you can actually get some movement in that upper thoracic spine for them to be able to move through that range of motion. But what I will commonly see is that patient that we see that they've got some neural involvement. We've identified that, we're working on that, but then we wind up with some cleanup that needs to be done in the shoulder itself in managing a tendonitis or a tendinopathy in that shoulder. Another lifter that we had recently, she just toughed her way out through a meet and wound up just having a total shit show in her shoulder that I was able to calm down. I was able to calm the neural portion down, and she still had an adhesive capsulitis that had persisted in the shoulder that I was having difficulty getting on the other side of. And I referred her out to an office that I have sent patients to in the past with interventional pain specialists, sports medicine and radiology. And I sent them out for what my understanding is the best procedure for that, which is a capsular distension using just saline. And instead, much to my disappointment, a new doc that had been brought in that practice that she wound up being fielded by, I had spent 3 weeks getting the adhesive capsulitis improved and improving her glenohumeral range of motion. And I needed some help getting the rest of that done. And they insisted on doing an MRI, which showed a predictable high signal intensity over the rotator cuff, which they insisted on using PRP on, and extracorporeal shockwave therapy. And those items sclerosed her cuff and sent her right back into it set her right back to grade 1 or step 1 of our attempts to manage the meat-based issue, and flared her up, reduced her range of motion, gave her worse pain than she had had at any point in the course of care. And that athlete, to this day, 9 months later, is still not able to put weight over her head. And I've got a sour taste in my mouth about that one. So yeah, evidence-based practice, eh? Not to mention the PRP was like they're recommending 3, 4, 5 PRP injections, and then a 3 times a week extracorporeal shockwave therapy. So Mark, when you talk extracorporeal shockwave therapy to me, that's one of the places my head goes to. I know that wasn't at all what you were recommending earlier. And as a follow-up to that too, mate, my MRI results came back, and it appears that I have actually avulsed the superior margin of the labrum off of the bone. So that I don't think is going to be, in using any kind of procedures trying to stimulate an anabolic process in the tendon itself, is going to help. First, we got to get some positional approximation of the labrum to the glenoid, and then once I've got that, we can go full tilt boogie on all those things. So that's what I got for the weekend. You guys got anything to follow up?
I just want to say thanks again, and appreciate you your little bit of detail on the McKenzie retraction of the neck with that extra extension. That I heard you talk about that, but I didn't really understand it in the upper course. I'm sure we'll get more of that. So
Yep,
thank you.
Absolutely. Yes, you're welcome. I look forward to seeing you, Mark, April 20 and 21. And for any of you guys over here on Facebook as well that are watching the replay here, April 20th and 21st, you can come take the 12-hour upper quarter course. And that is continuing education credits accredited by PACE. And for those of you that are lifetime members of the NeuroCentric Approach Online Academy, you can get $100 off of that particular course and all future in-person courses. Currently in negotiations to bring a course into Vancouver, hopefully this summer, and also in Fargo, and Phoenix, and Toronto sometime in this year, before the end of the year, hopefully. You guys be well. Go enjoy March Madness like I am. I've got my treadmill set up and my computer screen set up, and I'm going to walk my way through a couple of games today and put some miles in. I will see you guys next week, 9 a.m. Pacific. And in the meantime, stay curious, stay compassionate, use what you learn, and go out there and help some people. Take care, folks. Bye-bye.